We have done PIs, we have done SLTs, we have done cataract surgery also, but you will have a subset of patients who will require a filtration surgery. So in a primary glaucoma, should we go for a tube surgery or a trap? Dr. Bindu Ajith is the head of Department of Glaucoma at Comtrust Eye Hospital in Calicut. Will be speaking on the topic.
So now the dilemma is between tubes and trabs in primary glaucoma. Before we choose which one to go, the following things we do consider: what is the outcome, and we know the efficacy of the two procedure, more importantly the safety, and then the ease of doing surgery, how able you're prepared to do the surgery, the learning curve involved in it, and definitely the cost, repeatability, and the evidence of the literature that supports both the procedures. And as we all know, trabeculectomy is the gold standard. It has remained for so long, and it is the most commonly performed procedure. And the plus points or the advantages of the trab is it still remains the first choice, and it can be performed in advanced disease when your target is very low. It is proved to have a high success rate, and yes, it has a less learning curve, and the time required for the surgery is less. Yes, you can repeat the procedure, and cost-wise it is affordable, and there are n number of literatures supporting its success. Yes, the downside of it is these serious sight-threatening complications like the hypotonic maculopathy and the choroidal detachment and the bleb-related infections that we are scared of. So trab is not indicated in all types of glaucoma, and it also has post-operative interventions. Yes, you can increase the efficacy by use of mitomycin or 5FU and the releasable sutures, and adopting the Moorfield safe surgical technique. Yes, you can increase its efficacy. The next option we have is the glaucoma drainage device, which has both valved and non-valved. And previously it was reserved only for the refractive glaucoma, but now it is emerging as a primary procedure as an alternative to trabeculectomy because it has better safety profile. What does the literature says? It says that there is a downward trend in the trabeculectomy over the years, but there is an increase in the trend of GDDs, especially in the secondary glaucomas, because as mentioned, it has more safety, and it has a posteriorly located bleb with less risk of endophthalmitis, lesser post-op interventions, and yes, it can, when you are dealing with patients with ocular surface disease or thin sclera or patients with rheumatoid arthritis, yes, your choice will be a GDD. And as mentioned, in the secondary glaucomas, definitely you go in for a valve surgery or GDD. Now the downside of valves are, it has a steep learning curve. The cost involved is high. Yes, we have the alternative of the cheaper version of the Adi valve. It is less repeatable. Yes, you can go for one or two. The limited evidence supporting GDDs as a primary choice. The complications of the tubes, yes, you get a number of them. And the time taken for doing the surgery is definitely more. So it remained a choice as a secondary glaucoma and not the primary glaucoma. But now we'll just see the studies. The TVT study here, it studied actually it as a secondary procedure where a previously cataract or failed glaucoma surgery was done, and it showed that tube shunt surgery were more likely to maintain the intraocular control and avoid persistent hypotony and reoperation for glaucoma patients. The incidence of post-operative complications were found to be higher in trabeculectomy group, but tube shunts had a higher success rate compared to trabeculectomy. Now the primary procedure, the results of 1 year, 3 year, and the 5 year, what does that has to say to us? It was a multi-center study where patients were randomized to trabeculectomy or the bowel implant, and the primary outcome was the rate of surgical failure. And at 1 year, it showed that trabeculectomy performed better with a higher surgical success rate, but the frequency of serious complications which produced vision loss was more with the trabeculectomy group rather than at the tube group. But when you come to the 5-year group, the IOP reduction was almost same in both the group. So that is the IOP reduction. In the tube group, it was a little more than the Trab group, both in the 1 year and the 3-year group. But when you come to the 5 years, it is almost same. There was no statistical difference between the two. But when in the 3-year group, you have a difference of around 2 millimeters of intraocular pressure between the two groups, where Trab performed better. But when you come to the 5-year, it is almost same, with no statistical significant difference between the two intraocular pressures. But when you come to the complications, the early postoperative complications was more in the trabeculectomy group, with shallow AC, leaks, and choroidal effusion. But when it come to the late complication, it was almost same between the tube and the Trab group. And the rate of reoperations were more in the trabeculectomy group, but they included laser suture lysis, needling, all that as a reoperation. Another study which showed the comparison between Bowelt and the Trab also showed the intraocular pressure control was similar between the two, and it also showed the number of glaucoma drops after surgery in Trab groups was much lesser than the tube groups. And this was a survey conducted in the American Glaucoma Society on the preference of primary surgery, and it showed that the GDD has increased and the trabeculectomy has decreased, but still trabeculectomy is the most popular primary incisional surgery. So with all this, we have all the Western literature studies available comparing tubes and Trab as primary surgical procedure, but in India, we know that Trab is much safer in our hands. And I think we opt for Trab in all cases of uncomplicated primary glaucoma, except for when you are dealing with a scarred conjunctiva or thin sclera, or you have a risk of hypotonia or risk of severe visual loss, where you opt for valve devices. Thank you.